Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com. All right, everybody, welcome back to the DaVinci Hour podcast. I'm here this week with Dr. Todd Hanna, a oral and maxillofacial surgeon in New York City. So Dr. Hanna, thank you for joining the podcast. Happy to have you here.
Great. Thanks, Maxwell. Thank you for having me. Excited.
Of course. Maybe give us a little background on your educational and training path, how you got to where you are today.
So my background, my educational background after college is started in dental school. So I'm a native New Yorker. I went to NYU for college, and then after college, went to dental school, knowing I wanted to do oral maxillofacial surgery, but starting in dental school. From there, I went into residency, which is a combined medical degree and 6-year oral maxillofacial surgery residency program at University of Alabama at Birmingham, not far away from where you are in Atlanta. So I spent 6 years there, including the medical school. From there, I did one fellowship in Baltimore in head and neck surgery and microvascular reconstruction, based, oncologic reconstruction in Baltimore, Maryland, at University of Maryland Shock Trauma, and that is a fellowship that is mostly for oral maxillofacial surgeons that want to get into head and neck and microvascular. So when I was done with that fellowship, looking for a job, I came across an opportunity to do a second fellowship with the otolaryngology department in full scope head and neck surgery, everything from thyroids to skull base, and begin my reconstruction career back here in New York at Northwell, Lenox Hill Hospital, which is part of Northwell Health System. And so after that fellowship, I stayed on as a volunteer faculty status at Lenox Hill, Northwell. I did probably the majority of the head and neck and facial reconstruction over the last 7 years, but also started my private practice. And in private practice, my scope was a bit different, but in the hospital setting, I was largely doing the microvascular reconstruction. So that's really how it evolved.
Gotcha. Yeah, that's pretty cool. So it sounds like you do a wide variety of cases, and I definitely want to get into that. I'm curious that fellowship at Shock Trauma, that had to be one wild experience. I'm sure you saw all kinds of traumas, and then on top of it, like you said, a lot of oncologic reconstruction. I'm sure that was a standout experience.
There was a lot of trauma that came in, but unless they were getting a free flap, like a microvascular flap, I didn't have to manage it. But interestingly, in Birmingham, the trauma experience was pretty insane. I think University of Alabama, UAB trauma experience is as busy as anywhere. So I had gotten a lot of that there. At Shock Trauma, we were doing a lot of the free flaps for some trauma patients. So, gunshot wounds or some massive defect, we would do the microvascular part for that. But Baltimore is a crazy town. I don't know if you've been or not, but yeah, all sorts of stuff would walk through the door there.
I'm sure I can imagine. And so now you're in private practice, like you said, and then it sounds like are you still on staff at Lenox Hill? So it seems like you're kind of a mix of both your private practice world and then maybe some more like academic or private-demic aspect to your practice.
I'm also on faculty at Mount Sinai, and I'm just starting to bring cases there. And my scope is kind of transitioned to, I always had a strong interest in aesthetic reconstruction, aesthetic surgery, the face and jaws. And my scope of practice has kind of evolved into much more aesthetics, chin aesthetic surgery, jawline surgery, neck aesthetics, double jaw surgery, facial implants, things like that. So that's the bulk of my practice at the moment. And then I still do a fair amount of reconstruction in terms of microvascular and other types of flaps. But it's evolved to be much more into the aesthetic procedures.
Very cool. Very cool. I guess for the listeners who maybe are a little bit naive to the field of oral and maxillofacial surgery, for me, like my personal experience, I saw an oral surgeon, like I'm sure most people do. They got their wisdom teeth taken out when they were a kid. But it sounds like clearly from what you're telling me, it's a much more broad and complex field than just doing, maybe surgeries like that in the office. Maybe give us maybe a broad overview of the field, if you will.
Yeah, it can be. I think the beautiful thing about it as a profession, as a specialty, is that you really have a lot of opportunity. I have colleagues that really just want to do more standard oral surgery procedures, wisdom teeth, dental implants, maybe a jaw surgery here and there, and they're very happy with that lifestyle. And that's an awesome thing. In fact, that's the majority of people that come out of training. And you can't blame them because they're fun procedures, they're high satisfaction procedures where patients are happy and do well, and you can make a living and enjoy your life. I've always been a little bit more on what is it, sadist or something. I kind of like to torture myself a little bit. And I always try to pursue the things that were the most challenging. So if you want to do more advanced procedures, you can do additional training, you can do additional fellowships, and those will open up the door for more complex, if you will, procedures.
Gotcha. Now I'm curious, you mentioned your path involved going to dental school and then also medical school. Is that a requirement that you have to do both dental school and med school? And then maybe walk us through like the standard pathway towards oral and maxillofacial surgery.
So just a little history on it. So the surgery, if you go back to probably early 1900s, the specialty really developed as plastic and oral surgery. And it was actually a group of dentists that would really largely treat, wounded veterans, facially wounded veterans. That group of specialist dentists, if you will, diverged, and they became oral maxillofacial surgery and plastic and reconstructive surgery. And that's where the specialty really became its own thing, somewhat as we know today. And the oral maxillofacial surgery were largely exodontists. They would take out teeth and they would do trauma on wounded veterans, things like that. Over the years, the specialty evolved, as all specialties do, to incorporate other types of surgeries like cleft and craniofacial, facial aesthetics, head and neck cancer, microvascular reconstruction, trauma, or high-level trauma. So those became subspecialties that you can get into, but you more classically can get into a lot of those subspecialties from plastics and reconstruction, or even from ENT, head and neck surgery. So the specialty, again, began to evolve, and I'd say probably in like 1950s or so, there's a little bit of debate as to where the first dual degree program came from. Some people believe it was actually University of Alabama by the late chairman, Scotty McCallum, who recently passed away. But he is thought to potentially develop the first dual degree. And he was an oral surgery resident at UAB. He graduated dental school from Tufts. And then during his residency, he wanted to get a medical degree. So he kind of laid out the groundwork for going to medical school. That's one story. Some people say it may have been someone in Dallas that had the first dual degree program. So it's a bit debatable. But essentially at around that time, the doors opened to obtain a dual degree, but it was elective, right? So you didn't have to do it. Most people didn't want to do the extra couple of years because they didn't feel they needed it. As the years progressed, more programs became dual degree optional and then dual degree required. So now at the current moment, and the statistic may be a bit dated, but I believe it's about 50-50, meaning half the programs are dual degree and half the programs are single degree, meaning you just have a dental degree. You know, the scope of those practices kind of varies. Like there are some of these single degree practices that have a really awesome scope and do a lot of really intense stuff. And then there are some dual degree programs that really have a more private practice type scope, which is a little more limited. But for the most part, if you really want to do the broader scope, it's probably better to do the dual degree.
Gotcha. Okay. And then it sounds like do you have to do some general surgery training in there, or is it more just kind of like a intern year in the general surgery department?
Yeah, so we do a general surgery year. We do actually an intern year. And that's kind of evolved a little bit over the recent years because a lot of programs are becoming like, you know, like for example, vascular surgery, you can now do, or endovascular and vascular, you can now do direct residency for those, right? Whereas in the past, you would have to do a general surgery residency. So a lot of the programs are evolving, and a lot of those intern years for gen surg are changing. Even residencies like ENT, at every program, they don't always do that general surgery year, or they have very little general surgery time. I did, you know, in my program at that time, we did 8 months of general surgery and then 4 months of anesthesia. So the general surgery 8 months would be, we were a non-categorical intern, just like the rest of everybody else. And we would do all the rotations, right? The 4 months of anesthesia, we would spend really working with the anesthesiologist, intubating, pushing meds, you know, all that. And the reason why we do it that way is because part of our specialty involves a lot of office-based sedation. You know, we do our own IV sedation classically, and that prepares us for that. You know.
Gotcha. Okay. And then it sounds like from your telling me, most people don't do fellowships after they graduate, or is that, I guess, or is that becoming maybe more common in more recent years? Or
I'd have to look at the numbers. I'd say most don't. Clearly, most don't. If I had to speculate, maybe 5% will do a fellowship, and again, it's usually people that are really geared towards academia and hospital-based careers, but not always. Kind of like myself.
Gotcha.
It doesn't always work out like that. So.
Okay, and I guess maybe tell us a little bit more about the head and neck and microvascular aspects. I think that's really cool, and you did a whole fellowship in that. And then did you do that fellowship with maybe some plastic surgeons, ENT surgeons as well, and have was there some overlap, I guess, in those procedures with what those specialties do?
So the program in Maryland where I did the microvascular training it was an OMS fellowship, and we were doing at the time the majority of the flaps for the entire ENT and OMFS resident programs, but we worked very closely with the ENT program. And they had a couple flap surgeons, one facial plastics, one head and neck trained, and I would work with them as a fellow, and then I would work with my attendings, my microvascular attendings. So we had a really good relationship, and I learned great things from working with people from different specialties. When I came to Lenox Hill for the second fellowship, I had already had that microvascular training, so I started actually doing flaps as a fellow. I did my first flap about middle of my fellowship years, the second fellowship. And I worked a little bit with the plastics guys at Lenox Hill, but largely I kind of just developed my own thing there. I have to say, back in residency at UAB, we did a lot of the free flaps as well. We were very busy there and worked very well with the ENT and plastics departments there. So I'd come into the first fellowship with 40 to 50 free flaps, as first assist on them. So a lot of comfort. Yeah, a lot of comfort going in.
Awesome. So I guess now how would you describe if you could ballpark it, even your split between, maybe traditional OMFS, aesthetic surgery, and then this, microvascular and reconstruction surgery?
Yeah, it's a good question, because I constantly try to assess it myself, and it seems to change, year by year. But I'd say at the moment I'm probably about 80% aesthetic face and jaw surgery, whether it's genioplasty, chin implants, jawline implants, neck lifts, cheek implants, double jaw surgery, anything in that realm. It's probably about 80% that. And then probably about 20% head and neck reconstruction. And that's my hospital or surgical kind of practice.
And so like the aesthetic surgery you do, is that exclusively part of your private practice? And then for your private practice, do you run out of like an outpatient surgery center, or do you do it like in-house at your own office? Or I guess, how does that all work?
Yeah, so we have a outpatient surgery center that we can use. I don't always have the need to. I do most of the stuff in my own office. I have operatories here. I have the ability to sedate my own patients, or I can bring in an anesthesiologist to do the sedation or anesthesia. I work closely with some colleagues that have full operatories for general anesthesia, so I can always do combined cases in those settings. And then I could also bring patients to the hospital for outpatient treatment. But I'd say most of it I do in the office in my own operatory.
Gotcha. Okay. What would you say your typical week split is between, like, procedures, surgeries in your office, clinic time, seeing patients in the outpatient setting, and then your reconstructive cases at the hospital?
So at the moment, I do 3 to 4 days. So about 3 days where I'm actually seeing patients or treating patients in the office. I get about half a day of administration to catch up on notes, and then a day and a half to 2 days a week in the hospital doing either jaw surgery or head and neck reconstruction. It's nice when I have that half a day or so to catch up on notes. Otherwise, it's doing it on the weekend. But you need the administration time.
Yeah, I can imagine. That's a pretty busy clinical schedule. What is your call like? Do you take call at one of the hospitals in New York? And I guess when you are on call, what type of cases do you typically see?
We get. So I take. I believe it's 4 weeks a year at Lenox Hill, and then I'll be on the call schedule at Mount Sinai. So I've yet to get that one. It's largely trauma or odontogenic abscesses or infections. So anyone that has like a facial swelling from a bad tooth, or facial fractures, things like that.
Gotcha. And I'm curious, for people thinking about, going out on their own or joining a private practice, is taking call at hospitals like how you do, or multiple hospitals, that kind of part of earning your operating privileges at those places? Is that?
It's part of the agreement that, you can operate there, but you have to take call. That's how most places do it. Some people have a setup where they actually get paid to take call. I have heard of that. That's not how it is here, at least for me. So.
Gotcha. Yeah. When starting a private practice, are you a solo practitioner, or do you have partners that you work with? And I guess maybe kind of walk us through how because you spend all this time in academic centers and then you venture out either on your own or you join a group. How, maybe tell us a little bit of your story about that, how you got started in private practice.
So I always, I wanted to be a surgeon since I was a kid. And my primary goal, the reason I went the route I did, I learned about oral maxillofacial as like a teenager, reading I was reading an article in the New York University paper. And I was like, that's what I'm going to do. So I went into college knowing what I was going to do. My brother was going to dental school. So he's my older brother. So I kind of followed his footsteps a little bit there. But I always knew I wanted to do surgery, and particularly facial surgery. When I got into residency, I really felt strongly about having an academic career, which is why I really pursued the fellowships, right? I didn't even just do one, I did two. So it's kind of crazy that I didn't go into an academic career. What I found was when I was out and I was interviewing at great places, you know, I was close to taking a job at UPenn. The full-time faculty at Lenox Hill offered me a position where I'd be full-time within the health system. But what I found when I was negotiating with these contracts, that for the amount of time that I trained, and as hard as I trained, and the sacrifices in moving to these different places for the best programs that I could get into and things like that, I really felt that I didn't want to like be in student debt forever. You know, I had a tremendous amount of student debt. You know, I finished training at 36 and kind of had like a short period of window where I could kind of make enough money to pay those off and still have a life, right? Like own a home and things like that. Also, like you know, the politics in the academic setting can sometimes be a little bit of a deterrent. Let's be real, right? The politics isn't always the best. When I got out of training, I just couldn't bring myself to kind of sign those contracts. So I kind of, I guess somewhere in me all along, I knew I kind of wanted to create my own brand, my own practice. So I negotiated a contract to join another surgeon as an associate. And he just, you know, wasn't really an honest situation. So I didn't sign that contract, and I just opened my own practice. I kind of did it on a whim, because one of the things that was happening during that contract negotiation, as I was finishing my fellowship year, the second fellowship, getting close to the end, the contract seemed to be really stretched out. You know, they would slow things down, so to speak. And then I found that I was past the point of graduation. I still didn't have a signed contract agreement. And then I really felt pressure to start making money. And I think that was probably somewhat strategic on their part. So what I did is I started to look for different avenues pretty early, and I found an opportunity where I could work out of these other oral surgeons' office. So in a sense, I would rent space from them. And they were, you know, good guys. They had a big office in Midtown Manhattan, and we worked out something that was fair. And I just put up a website and started just grinding. You know, it was really quite. It was a bit of a frightening time because I didn't know where I was going to land. But I also didn't say no to any of the cases that were coming to me from the hospital. That's the one thing I did that probably was one of the biggest elements in the practice growing. I never said no. No matter what, no problem, I'll be there. It's, you know, it's a pharyngolaryngectomy reconstruction, no problem. Scalp reconstruction, no problem. Nose, no problem. Tongue, no problem. Like I just did the case. And you know, within the first couple of years, probably the first 3 or 4 years, I had somewhere around 150 free flaps, 100% success rate of them, microvascular success rate, never lost a free flap to this day. So they were giving me more and more, and I would just keep doing them. It became hard to really build a private practice and do those big cases, you know, because to wear both hats became hard. So over the last year or two, I really kind of weaned down in the reconstructive stuff so that I could focus a little bit more on the practice and the aesthetics, which is the part that's really been growing the most.
Gotcha. Yeah, that's interesting. You know, I've heard from some others as well, the similar types of things. I forget, it's 3 A's, right? Be available, be affable, and I think able is the last A. And you know, I think that speaks to people think it's kind of a cush, easy life, but really, from what you're telling me, and then from what I've heard from others, is you really need to, you know, especially when you're first starting out, like get your name out there, give your cell phone number out to referring docs, you know, make yourself just like how you described, be very available for, you know, any type of consult, and not and be averse to saying no to consults, if you will.
And also you have to take risks. You know, if I look back, there were a number of cases that I did that if I was giving advice to someone, I would tell them not to do. You know, like severely comorbid patient, you know, and risky case and radiated patients and things like that. But when I really think about it, those risks and those cases and being not willing to be, like you said, available, is really probably what separated me a little bit and gave me the ability to build what we're building here. So.
Gotcha. I'm curious, there's some IR physicians, in my field that kind of run their own even solo practices or even solo outpatient procedure labs, if you will. And they talk a lot about taking referring docs out to dinner or literally going door to door, if you will, and introducing themselves, even their card out. Did you have to do any of that, like with maybe like general dentists or other type of like primary care referrals for your practice?
It's not really like the model that we have here. There's a guy named Dennis Krause he's a pretty renowned guy in the ENT head and neck world, and he was one of the guys I did my fellowship. I did my second fellowship with him, and became one of my best friends and great mentor. Even to this day, we're very close. And I started doing a lot of the reconstructions with him, so I couldn't have done any of this without him opening a lot of doors for me. But then again, when he offered an opportunity, I took it, and I never said no, even to the risky ones. So that was a big part of how I developed the head and neck scope that I had, the microvascular stuff, I mean. And then for the oral surgery and the facial aesthetics, I'd say the oral surgery, I had some friends that were in the city from dental school, and I reconnected with a handful of them. So I had some influx through that. And then the aesthetic stuff really it's kind of, the type of thing where if you're able to utilize social media to share your cases and people can see the results and can see the thought process behind your surgeries, through the comments that you make about it, then they kind of, build themselves, in a sense. So they were all very different, but I certainly don't just go around trying to cold call other doctors or dentists or anyone to try to take people out to dinners and stuff. I work with a small group of specialists and general dentists and dental specialists that I like their mindset and their treatment philosophy, and that allows us to treat patients in a way where there's not a lot of friction, and it's really good for the patient because the mentality and the philosophies are the same. So that's really how I do it. Some people really throw big parties. They try to take people, out to dinners and fancy shows and sports games, and that's great, and that may work for them. But what I found is working with people that you like and that you think similarly to it's hard to beat that. No fancy restaurant is going to beat that, right?
Right. Yeah, definitely.
In the IR world, how do you guys do it? Is it largely that you have to be hospital based to get the referral patterns, or?
Yeah. So, I mean, obviously you can go the academic route and, you have the referral base, built in there, especially on the inpatient side. And then one of the challenges we face in IR is, making people more aware of what we do, or that we have, less invasive options to, a wide variety of pathology. But yeah. And then out in private practice, there's these large groups out there that have usually contracts with like health systems, like you have as well, similar to you in oral surgery. But then also it's a lot of I think marketing to primary care physicians, getting that. And then a lot of it's also, from what I've heard, is like a case, for example, we do is prostate artery embolization for benign prostatic hyperplasia. So it's a lot of talking with urologists and kind of making them aware of that. Hey, we have this other option, maybe we can work to kind of like what you're talking about with your colleagues, instead of butting heads on this or competing for these cases, we can work together to, do what's best for the patient in a lot of cases. So that's kind of a cool thing that's evolved out of that.
You should, I've used IR before for sphenopalatine pseudoaneurysm coiling.
Oh, wow.
So you should reach out to some oral surgeons that do a bunch of jaw surgery, because that might be that might be a niche for you.
That's really cool. I'd love to see one of those cases. That's awesome.
Yeah. And then some of the guys do the feeding tubes. IR will place the feeding tubes through ultrasound.
Oh, right. Yeah. Yeah, we do it for a lot of, I've even just seen it now in my few years of training, for head and neck cases. We do a lot of like G tube placements and things like that. We have a pretty good relationship with ENT and some of those surgeons here as well.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
I think you touched on something I wanted to ask you about as well. Obviously, the one of the ways I came to know who you are is through your large Instagram following, and you post a lot of really interesting and cool and educational cases on your Instagram account. I'm just curious, like, how you guys started doing that, and kind of what's, a lot of people are starting to try to do that these days, and how you've been able to so successfully do that, and I'm just curious how that's helped your practice, and then also if it's helped you kind of professionally in other ways as well.
Yeah, it kind of goes back to that time period around 2016, 17, where I was kind of like in this like little bit of the bridge behind me was burnt, in a sense, like I had no other option, right? So I started to really explore ways. I knew I didn't want to sign that contract. I didn't want to work with that guy. So what am I going to do? So I started to explore ways to really grow the practice, and that's how the page started. As far as the way I developed it, I honestly just started posting cases that I liked and that I was passionate about, and I would talk about it. And in the beginning, I remember some of the stuff, because at the early stages, it was very heavy. If you look at the page and you go back, it's very heavy in the reconstruction stuff. And now it's evolved into a largely aesthetic surgery page, face and jaw aesthetics. But I remember getting a lot of like comments about this being too like graphic for social media. But what I was building, I wasn't building a following of general population. I wasn't building a following of lay people. I was building a following of colleagues. And I think that's really important, because I think that's really how it starts for us. Meaning, I think the first thing we have to do is we have to get a certain respect from our colleagues. And then once you get that transitions into a respect or some degree of a reputation amongst patients. But I think it has to start professionally, at least for the things that we do. Then I made the account a little bit more personal and started doing more like fitness stuff and working out and some kind of like family stuff. And the following grew a lot, but it started to grow with what was probably more lay people. But what I found was that didn't really transition into successful practice. In fact, maybe kind of the opposite. If someone's spending too much time on social media, how much time are they spending taking care of patients? And I then parlayed it back into really, I share a little bit of my personal life, but very little. It's really largely educational about procedures that we perform and things like that. Whether the following is, whatever it is, it leaves a footprint for me. It's almost like we're an artist, and if you're an artist and this is your exhibit, you have an exhibit that you could easily share with the community. Anyone who wants to look up your work and learn about you can access it very easily. It's much more easy to navigate than a website, and much more easy to find people than a website is. So it ends up becoming almost like our exhibit, you know. And I love to put these cases that I'm very passionate about it. I love to put them on display and to share the details of it and you know, the nuances of it. I enjoy that. So whether I post something and everyone likes it, or I post something and no one likes it, I don't really care that much about it. Obviously, we want our work to be acknowledged. That feels good for everyone, but I don't care as much about it as I might have thought I would. I enjoy the process of creating the content and sharing very much.
No, that's awesome. And, thank you for providing such a great resource. I'm sure a lot of students have learned, including myself, more about, what your field is and what you're able to do. And I think kind of what's the challenge, like I was talking about, maybe is that, when people think of oral surgery, they may not realize that you do all, your practice is much more broader than the traditional scope of oral surgery. So I think that is very insightful and informative as well.
Yeah, I mean, well, that goes back to the training, though. Like University of Alabama for OMFF, for oral surgery, it's probably the number one, two, maybe three program in the country. Very broad scope. Has had amazing people that develop the program. I'm actually lecturing at Peter Waite's retirement event this weekend in Gulf Shores, and Peter Waite was he was an oral maxillofacial surgeon, chairman of the residency program, and he was the first OMS to become president of the American Academy of Cosmetic Surgery. Patrick Lewis, the program director, has been involved and head of every organization that we have. They put out some of the most world-renowned surgeons. So what I am able to do is a result of the places that I went and the people that I've trained with. Baltimore for microvascular and head and neck, it's like, under Bob Orden, Josh Lubeck, those guys are, they're as good as they come, in that field, and they're respected amongst anyone in head and neck, regardless if you're OMS or ENT or whatnot. And then to do a year with Dennis Krause, not even the same specialty, while he's president of the American Head and Neck Society, it's almost like a dream when I look back at it. These opportunities were just like, it's incredible that I was able to have them, and I'm very grateful for them. But those are the reasons why the scope is what it is. It's not like I just want to do something and I do it. I had these experiences. I did this training. I learned from these people, and then I took what I learned and I cultivated it into something. But it's really about finding the opportunities to get the skill set. It's not about just saying, I want to do this. I want to do a heart transplant. And you have to learn how to do this stuff. Because these are people. This isn't like this isn't playtime. This isn't a video game. You know what I mean? These are people. You have to always remember that. But yeah, I mean, it's really about finding the opportunities to get the training that you need.
That's awesome. And I mean, having amazing mentors like you had, I think is so critical. And I think you hit on a good point too. I think it's, and I'm starting to learn this as I progress through training, is that, yeah, it's cool to think you want to try and do something, but I think getting those reps and then learning from, like you said, like yourself, learning from the people that actually have established these procedures and these surgeries and things like that is so important for your own education and then also building your credibility, I think, going forward, probably.
Yeah, it's like 10,000 hours, right? It's a real thing. Like Maxwell Gladwell, Malcolm Gladwell. Thank you.
Yeah.
Yeah, I mean, it's about getting those reps in, and it's about, when you spend time with really amazing people, even in a subconscious level, you take a lot from them. And, even things you don't even realize, even thought processes, which really correlates to judgment, which is probably the most important thing a surgeon could have. It's as important as hand skills, as important as a critical eye. Judgment is a cornerstone of what we do. And judgment can be learned. And the way you learn that is through experience of people that have wisdom. And people that have wisdom have it because they've seen many different scenarios. They have that experience, and that's why they have that judgment. So you can make a whole bunch of mistakes and learn the hard way, or you can really spend time with really exceptional people, and you can gain a lot of experience through them.
Gotcha. I'm curious, how did you seek these, these opportunities out? Where was it, I guess, what would be your advice for finding, good mentors and learning from great people? Is it reputation? Is it talking to maybe people that you're currently, learning from and talking with? Or I guess I'm curious what your thoughts are on that.
There are things you can fake and things you can't fake, right? And you have to have a general enthusiasm and a curiosity and excitement about your craft, right? You have to really be willing to do almost anything to be the best at it. And that's palpable, and people can see that, they can feel it when they're in the room with someone like that, almost to the point where you're naive. I spent, up until I was 36, I didn't even care. I was collecting student debt, by the boatload. My student debt was insane. I couldn't care less. I didn't even think about it until my forbearance payments started kicking in. And the deferment period ended. But I was just so enthusiastic about it. I was willing to go to Alabama for the best residency. I was willing to go to Baltimore into one of the hardest fellowships. I was willing to do another fellowship. So having that excitement, I think, is what gave me these opportunities. And because I think there was something about the excitement and the enthusiasm that I had that made these people say, you know what, I want to give this guy a chance. So I really believe it's that. The other part of it is a little bit of luck. It's hard to say that that's not an element. These opportunities just opened up in some way as well. Particularly that last fellowship with Dennis. I was fortunate enough that spot was even still available, and that they were willing to take someone of a different specialty. My co-fellows were 2 facial plastics and a neurosurgeon. We were all doing this fellowship. I was doing the head and neck cancer. One guy was doing the skull base. The other 2 were doing like this combined aesthetic and head and neck kind of rotation. But they took a chance on me, really, because no one had done it from my background before, so they didn't know how that would work out. But it worked out really well. So
that's awesome. I'm curious, you do all these different types of cases. What are some of the, like, I guess, either most gratifying or most fun, if you will, or technically challenging that you enjoy doing out of all the different cases that you do?
I've learned a while ago that people are driven by different things, right? What I'm motivated by is outcome. I thoroughly enjoy seeing good outcomes, seeing great outcomes. I thoroughly enjoy looking at the pre and post op photos and seeing even the minor details that are beautiful and elegant and all that. So I think it's really the ones that have the most meaningful outcomes. And a large part of what I mean by that is visual, but also by how the patients, how their personality changes, how their confidence changes. So the surgeries that I find the most enjoyable are probably the ones where the outcomes are the most significant. The outcome, meaning someone has a really horrible deformity from something, and you can give them this beautiful reconstruction and return them to feeling whole again and feel like they can face society. Or take someone who has been really self-conscious about a part of their face or their jaw, their neckline, and give them this really meaningful, beautiful, elegant, tasteful surgery. That's what I enjoy the most. So it's not one procedure that I enjoy the most, but it's really the procedures that have the greatest outcome. Most of those happen to be like the double jaw surgeries, the aesthetic chin and jawline surgeries, the reconstructive surgeries for like facial defects, whether it's cancer or trauma. Those things where you see the greatest, the most significant outcome.
I'm curious, what types of, there's obviously a lot of, there's a lot of science in what you do, but there's also, I imagine, a lot of art in what you do and craftsmanship. what types of, do you use like software or things like that to prepare for your cases? I think I've seen some pictures you've posted on some like the 3D models you've made it. I guess what kind of all goes into some of these cases, and what kind of interesting tools do you use for that?
Yeah, so it's funny. So interventional radiology is probably like 80% science, 20% art, if you will. Right? Meaning
Yeah. Yeah.
certain algorithms you follow, and if you do things right, most of the time you'll stay out of trouble. And maybe 20% of the time you have to be a little creative. Vessel has a little branch that you need to find a way in, things like that, right? With my type of surgery, it's probably 80% art, 20% science. Meaning there's certain things you have to do, and you have to make sure you do properly, or you're going to have a problem. But 80% of it is judgment. There's no, you can read the textbooks and you can learn certain things, but a lot of it is really aesthetic judgment. And the way that I do it is I sit down with a patient. We have a consultation. I listen. I do most of the first consultation. I'm listening. I want to understand what their thoughts are, and I also want to understand what their expectations and knowledge is, right? So I'm listening. Towards the end of that consult, we do photographs. We take photographs. We take a CT scan in my office. I have a CT scanner for 3-dimensional soft tissue and bone imaging. I look at these things. I do a sketch of them with them. I do it right chair side. And I show them the things that I think make sense aesthetically and functionally, and that are safe. Safe in terms of a safe movement of part of the facial bones. I ask them for their input and their thoughts. Most of the time, patients are very happy with that sketch, and with all the listening and with my own assessment, I'm pretty good at being able to nail down what they're looking for with that. Sometimes we modify it. From that, I use the CAT scan that takes both bone and skin imaging, and I can do bone surgery on them or implant surgery on them, facial implant surgery. And I can get soft tissue predictions of what they'll look like, kind of, all right? My sketches tend to be more accurate than the soft tissue predictions, just because the computers are very good at being able to predict how bones will move, because those are solid structures, but skin, fat, muscle, the way that moves as the bone structures change, it's not so good. So I use the combination of both to really come to a treatment plan. Once I agree on a movement, or once I am happy with a certain movement of facial bones or a structure of implants of like chin or jawline or something like that, or cheek, I accept it, and the company will mail me the custom materials, meaning custom cutting guides, custom plates and screws, custom implants. So it's everything I do is specific for those patients. I don't do any non-custom work. I stopped doing it years ago because the outcomes just are not as good. And that's really how we do it. So
That's awesome. I mean, it's amazing how much goes into each and every case. That's pretty cool. And it's cool to hear that you use imaging as well as a radiologist in training. That's cool that you use imaging as part of that as well. Kind of segueing a little bit as we close things out here, obviously it's also clear on your page that, obviously you maintain personal fitness, like you mentioned. I guess, what's your advice for that? You did a lot of years of training, and, as you only have so many hours in the day as a trainee. And then even as yourself as a practicing physician, is it a matter of just making it a priority, or I guess, what is your advice on that? I'm curious.
So first thing is, don't get injured. Right? Try not to get injured, because that sets you back, and that if being fit is important to you and you have an injury, it really messes with your life a lot. So do your best not to get injured. As far as making it you have to make it a priority. It has to be a lifestyle. You have to be uncomfortable if you don't get to move, if you don't move your body that day. It has to bother you at night. That's really just the only way, because there are days that you are just going to be too tired, and it's so easy to rationalize not exercising. But that will show. It's like anything else, right? It's about getting the reps in, like you said earlier. When I was an intern at Alabama during that first internship, the first year, our intern year, it was a really, really busy year. It was probably the hardest year. It was harder than the general surgery internship. It was, as hard as the fellowship in Baltimore, if not harder in terms of hours. And my body just deconditioned. It was probably the worst shape I was ever in. And I remember trying to get back in shape. In the later years, it was just hard, because you're sleep deprived, you were eating crap all year just to try and keep your energy levels up, right? And the amount of stress you're running on, like stress hormones for the whole year. And it's really hard to get out of that rut. So, once you get out of that rut, stay out, keep the routine. Even if you're tired, do something. Even if it's just stretching or rolling on a foam roll, do something. And then also try not to get injured, because that also gets you in that rut. That's hard to get out of. So that's what I'd say. Try to find a routine, whether it's morning or night workouts. I think both are fine. If you can work out in the morning, it's clearly the best. All the evidence shows that. But if the best time to work out is the time that you can get to the gym predictably. And I'd say, some people say, like, should I do like hobbies or should I do a sport? And that's fine. That's fun. And if that works for you, that's fine. But, it's really hard to develop your body in a way that you need to for these kinds of careers that we have, and strengthen the core muscles. And it's really hard to do that in most sports. Like, you'll get a good cardiovascular workout playing basketball, but you're not going to strengthen your core the same way. You're not going to protect your back and your shoulder muscles and your neck the same way. So you have to do some form of strength training, whether it's like Pilates, yoga, reasonable weights, calisthenics. So I really urge people to get into some form of that, a resistance training of some sort. It's more valuable than a sport, even though sports are fun and important as well.
It's interesting you bring that up, the doing it not only just for your own personal fitness and health, but also for your ability to do your job and, probably get less fatigued. And then obviously also longevity. I mean, like yourself in our procedures, we're using, wearing lead a lot of times, which is a lot of,
Weight on the shoulders.
yeah, exactly. And standing for long periods of time and things like that. So I think that's a really excellent point you made. I guess if you noticed, you had that year of intern year where you were, obviously, and I can emphasize, I did intern year and at a county hospital. It was very, very busy. And I was probably likewise in some of the worst shape I've been in. And then getting back, did you notice you better able to do your job as a surgeon after getting back into shape that you wanted?
Yeah, clearly. In every round, you can focus longer, you don't fatigue as much, you're more comfortable while you're operating. You need to maintain physical health.
Gotcha. And then I guess my last question is beyond just fitness, what do you do outside of your work to unwind and kind of, give yourself that mental break from all of that?
Yeah, in many ways, I'm pretty simple. I don't need a lot. I'm very content with as the Japanese, there is a ikigai, the one thing, right? I'm very content pursuing one thing to be as great as I could be. I want to be as good as I could possibly be at something. So I don't need like a bunch of different hobbies. What I do like to do is I do like to spend time with my family, loved ones. I have a dog. I adore my dog. He's great. I spend time with him. We play frisbee in the park, things like that. And then, I like Formula One, but other than that, I don't follow a lot of sports. I always found them to be, for me, I felt like they were a bit of a time suck. I'd be watching like a basketball game and I'd be like, I really want to work on this case that I have coming up. And, I think about that, my mind would be straying. So I like that. That's my balance. My balance is in balance, and I'm happy that way. But that's not everybody. So, I don't need that much outside to decompress because my work is in many ways my decompression. It's kind of crazy because it's my stress and it's also my escape at the same time. but that's part of why I love it.
Gotcha. Yeah, no, I can definitely understand that. I think, as I was telling you before we started recording, I'm at the top of my clinical training. I balance my life with a lot of other, professional endeavors with, this and device development and things like that. So I totally get where you're coming from on that.
I could see that. I could see you going down those rabbit holes of stuff. That's pretty impressive. What were you saying the device company you were developing was?
Yeah, so the one we've developed a catheter device, and then like a balloon catheter device for navigating more tortuous anatomy, and then we're working on some sensor technology for stent grafts.
Interesting. So that's the art. That's the artistic side of it, for sure.
Yeah, definitely. It's like you said. It's it's so regimented and regulated, and there's the steps of the procedure or whatnot, or the clinical algorithm. But I find the outlet, like you said, that I have a creative side to me, and that's I think, it's interesting you point that out. That's kind of where I get that outlet from. Well, thanks again for joining us and telling your story and your advice. Really appreciate it. And I know you're really busy, and appreciate you taking time out. Lastly, how can people find you? I know you already have a huge following, but if new people want to follow you, what's the best way for them to find you?
So Instagram's the best. That's the platform. That's really the only platform I use other than our website. And that's doctor, spelled out DOCTOR .hanna, HANNA, as in my last name. And yeah, anyone who has questions, send us a message. I'll get back to whatever I can.
Awesome. Well, thank you, Dr. Hanna. We really appreciate your time and insight.
All right. Well, thank you, Max. I appreciate it. Thanks for having me.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as ebooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.